Thank you for joining our Ask the Expert series. And our topic today is genetics. And when we did a poll of all of our patients asking what topic they had the most questions on, genetics was the highest response. So we are very happy today to have Karol Rubin, a genetic counselor, presenting today on the genetics of Alport syndrome. Thank you so much, Karol, for providing your time today and your resources. As I mentioned before, you are able to ask questions at the end or during the presentation using the participant feedback feature, or I will be unmuting all lines at the end for questions as well. And with that, I would like to turn this over to today's presenter, Karol Rubin. Karol?
Hi, thank you for having me speak for this for the Alport Syndrome Foundation. I'm excited to be here, and I'm happy to answer questions as we go, or certainly I'll be leaving time at the end. So today's topic is called Family History Matters, Genetic Testing and Inheritance Patterns of Alport Syndrome. So today, this webinar is going to provide an overview of the inheritance patterns of Alport syndrome and discuss the benefits and limitations of genetic testing. So let's go back to some of our high school biology class, probably for several years ago for some of you. And we'll just do a little review that we all have cells that are inside all of our body. And inside of our cells are our chromosomes. And along our chromosomes are genes or genetic information that make up our instructions for our bodies to develop and function. And it's actually these genes that specifically code for proteins that are important for our body. And of course, genes code for color of our hair, color of our eyes, but also more important things, kidney function, the ability to hear, vision issues. So certainly these proteins are important in Alport syndrome. So if we broke open the cell, we would actually see a photograph of our chromosomes, and this is a picture of a typical cell with, we all have 46 chromosomes. They come in pairs. We get one from each parent, and both males and females have chromosome number 1 to chromosome 22. Those are the same in males and females, and they just number their chromosomes according to size. The chromosome number 1s are the largest, chromosome 22 are the smallest. Females have 2 X chromosomes, and then males have an X and a Y. So probably many of you know one of the genes for Alport syndrome is actually located on the X chromosome, so that difference will be important as males only have 1 X chromosome and females have 2. Males don't have a backup copy. So the 3 main genes that are involved in Alport syndrome are, one is on the X chromosome, the COL4A5 gene, which this is just the specific address of where the gene is located. So it's on the long arm of the chromosome X, and this is just a specific address of where that gene is located, 2.3. The other 2 genes that are for the autosomal recessive and dominant inheritance patterns are located on chromosome 2. And that address is to the long arm of 2 at 36.3. And so those 2 genes are the COL4A3 and COL4A4. So when we meet with families, the family history is very important for several reasons. One, to help figure out inheritance patterns and to just get more information from the family, but also the social part of the family history is really important. So typically when I meet with families, one of the most important things is we ask is about not only the person who's coming in for genetic counseling, what features they have, but who else in the family has features. Are there other people with the hematuria, with the blood in their urine? Are there other people with kidney issues, hearing loss, vision issues? And the second important aspect of the family history is really the dynamics of the family. As many people know, some people know a lot about their family history and health information, and some families share really freely, while other families are pretty just guarded and don't share a lot of information. So sometimes people don't know a lot of information, and it's not something that you go around to a party and say, oh yeah, I have blood in my urine, unless someone actually happens to ask. So Other factors that are important is to know, are all the family members living in the same city? Are they across the country? How close are they? Is there one point person that people talk to? So those are some really important factors when genetic counselors take a look at family histories. So genetic counseling, one of the big things that we can do, and we're master's trained professionals. We typically have training both in genetics and psychology. It's a master's degree program after most people have an undergrad in genetics or biology. But we know nowadays there's so much information on the web and on Google that people have access to information, but what's important is that they need also someone to listen to, especially after a new diagnosis. Obviously, having a chronic condition in a family can really change family dynamics and can cause a lot of stress. So genetic counselors really do a lot of listening and provide a lot of emotional support, in addition to providing education and explaining about inheritance and genetic testing. So let's move on to talk a little bit more about the different types of inheritance patterns. So typically when we take a family history, about 85% of the time, families have a family history of other people with features of Alport's, whether it's other kidney issues, hearing loss, or vision issues. So that's certainly most common. But about 10 to 15% of the time, there's no one else in the family that has features of Alport's, and so that's important. Those families, sometimes it's the result of a new change or a new mutation. Sometimes it's the result of a recessive inheritance, which we'll talk about in a few minutes. So this is a family that I saw a few months ago, a very typical family history that we would see in someone with Alport's. So this young woman came in, and her brother just got diagnosed with Alport syndrome based on a renal biopsy. And then when we took the family history, we noted that his mom had some blood in her urine. And then he said he had an uncle that had some sort of kidney disease and also had hearing loss, but never was officially diagnosed with Alport. So this family history is pretty typical of what we would see in X-linked inheritance. And that's the most common in Alport. So typically, X-linked recessive inheritance means that the gene change is located on the X chromosome. And typically, males are, this shouldn't say only affected, but males are usually more significantly affected than females because males, again, only have the one X chromosome. Females can be carriers, but can also have some milder symptoms because they have the 2X chromosome, so they have a backup copy. I'm going to talk in a few minutes about this skewed X inactivation, which is a concept of explaining why some females have more symptoms than other females. Typically in X-linked inheritance, you do not see a male passing on Alport's to a son, so there isn't any father-to-son transmission. And again, this is the most common type of inheritance pattern for Alport's, is the X-linked. So this is just another example of a family history that we see this. So we see the mom up here as a carrier, and then she has a son that's affected, but also has another son that's not affected. And then she has a daughter that's unaffected, and then another daughter who's a carrier that may have milder symptoms. And you notice here that the son has a son that's unaffected because he can't pass that on to the son, but the daughter can have a son that's affected. These are a couple other slides to illustrate that. So if a female is a carrier, then there's a 50-50 chance for her to have a son that's affected, and a 50-50 chance for her to have a daughter that's a carrier and could have symptoms. On the other hand, if a male is affected with the X-linked form, then all of his daughters will be carriers and may or may not have symptoms, and none of his sons will be affected. Okay. Any questions on that? Or I'm not sure I can look at the questions, but so let me just talk a little bit about this concept of skewed X inactivation. So all females have 2 X chromosomes, and in all females, randomly one of the X chromosomes gets inactivated or shut off. So that happens in everybody, whether or not they have Alports or not. And so typically this activation is random. So sometimes one X chromosome gets turned off, sometimes the other. So what can happen is if for some reason the normal X chromosome gets shut off more frequently than the one with the mutation, then that individual will have more significant symptoms than someone whose chromosome with the mutation gets shut off more often. So that's why we can see some variability with females who are carriers. Some are a lot more concerned. Oh, I see a hand is raised. Let me see how I do that. I see Carol has her hand raised. Can you ask a question?
She's actually still dialing up. Let me unmute Carol.
Oh, okay.
She'll be able to ask her question. Carol, are you there? You raised your hand. You're able to ask your question now. All right. Well, Carol, if you'd like, you can post your question at the bottom, and we can get to it later. And why don't we allow the presentation to finish, and then we'll do all questions at the end.
Okay, perfect. And then I would look under the tab that has questions. Is that correct? Or okay. So let's continue on. So the next most common inheritance pattern is autosomal recessive inheritance. And this occurs in about 15% of people with Alport syndrome. So recessive means that someone needs 2 mutations, one on both of their chromosome 2s. So remember the other gene that's implicated in Alport syndrome was on chromosome 2. And so people with the recessive inheritance have mutations on both of their chromosomes, 2s. So in this picture, you can see that both parents are carriers, but typically in recessive, they usually don't have significant symptoms. But then both of them do have a son who's affected, and then they have 3 other children that one is not affected and the other 2 are carriers. So in recessive inheritance, both males and females can be affected, and it doesn't matter the males are not necessarily more affected than females. So this is another example where we can see both parents are carriers, and if 2 parents are carriers, there's a 25% chance for a child to be affected, and that can be a male or a female because, again, this gene is located on chromosome 2 and has nothing to do with the gender. And then, of course, they have other chances of 25% chance to have a child not affected at all, and then a 50% chance to have a child that's a carrier but not likely to have symptoms. So this is pretty typical when we see one person in the family affected and nobody else, is that sometimes it can be a recessive, autosomal recessive inheritance. Then the final type of inheritance pattern is the least common, only in about 5% of Alports. It's what we call autosomal dominant inheritance. And so this, again, is also a mutation on chromosome 2, but only one mutation is needed. One could kind of equate this as, say, we had a pair of genes, and we could use the analogy of a bicycle where there's 2 bike tires, and if one of the tires goes flat, it doesn't matter if the other bike tire still works, the bike doesn't work. So in this instance, having one mutation is enough to cause the Alport syndrome. So for someone who has Alports, there's a 50-50 chance of passing it on, whether or not it's a male or a female. And it is equally passed on by men and women. So I have a couple other slides here talking about the inheritance of dominance. So here we see a male person with Alports, and again, 50-50 chance to pass that on, whether it's male or female. And then here is a female who's affected, and again, 50-50 chance. So again, this is the least common. What's a little interesting about the dominant form is there's fewer there's less likely for hearing loss and vision issues when people have the dominant type of Alport syndrome. So let's switch over and talk a little bit about, let's see, I see a question here. Let's see, the word carrier is confusing for X-linked as women show symptoms. So that's correct. Some people maybe don't use the word carrier. Technically they are a carrier, but they also could be considered just having a milder form of the X-linked Alport syndrome. That's correct. So there is different language that can be used. So let's talk a little bit about why have genetic testing. So there's lots of reasons why people have genetic testing. Probably the most common is to confirm a diagnosis, especially when the clinical criteria haven't been met, or maybe they haven't had a renal biopsy, or as an alternative doing a renal biopsy, because genetic testing is just a blood test. So if we take a look at this family that I saw a few months ago. So this was a family. They didn't have a whole lot of information about their family, but they knew that there was a lot of women in the family, and they all had hematuria or blood in their urine. There was no family history that they knew of kidney problems or hearing loss, but they wanted to know if they had Alport syndrome. And so what we did was certainly we gathered some family history, and then one of the women did decide they wanted to have testing, because as you may or may not know, there's other reasons for having hematuria, not necessarily it's always Alport syndrome. So we did do some genetic testing, and it did turn out that the mom did have a mutation in the COL4A5 gene, which is the common gene that is in the X-linked Alport syndrome. And so we did confirm that this family actually had Alport syndrome, and it was important for them to have follow-up with their nephrologist, as well as getting their hearing checked and vision checked as well. So that was an important diagnosis for this family. Another reason to have genetic testing is really to help clarify the inheritance pattern. So sometimes it's clear by taking a family history, but sometimes it isn't. So I saw this family a few weeks ago, or this individual, actually, a young man who was diagnosed with Alport syndrome. He had a renal biopsy. It was confirmed, and he had hematuria and some hearing loss, but didn't know anything about his family history. He was adopted, and he wanted to have a family, and I think he assumed that he had the X-linked form, and so figured that all his daughters would be affected and none of his sons, but he wanted to really make sure before he started to have a family. So we did undergo genetic testing, and we tested for all 3 genes, and it turns out that he has the recessive form. So we found 2 mutations in the COL4A3 gene, and this confirmed that he had the autosomal recessive type, not the X-linked type. So for him, this gave him a lot more information that he would know that all his children would be carriers of the recessive form, but not likely to have symptoms. So this was important information for him to find out. There are other reasons to have genetic testing. Sometimes other family members want to know if they have the Alports, or was this a familial or inherited type of Alports, or was this new or de novo? And oftentimes other family members want to be used as kidney donors, so that's another real important reason to do genetic testing. So if we go back to this original family that I had seen, I had met with this young woman, and actually that's why she had come in, because she was interested in being a kidney donor for her brother. And so she wanted to know what the next steps were. So after taking the family history, we knew the brother was diagnosed with Alport syndrome via his biopsy. But what's very important before we do genetic testing is that we confirm the mutation in the family before we could test our patient that had come in. We need to confirm both that it's the X-linked type and also confirm the specific mutation. So we tested him first, and we did find a mutation in the COL4A5 gene. And then we ended up testing her, which we only needed to test her for the specific mutation. It was less expensive than testing him initially, because we had to sequence or look at all the different spelling mistakes in the COL4A5 gene. But for her, now we only needed to test for this specific mutation. And it turns out she did not have that mutation. So she was not predicted to have Alports, and she was able to be a kidney donor or on her way to the next steps for the kidney donor for her brother. So that was pretty exciting for this family. So a couple other reasons why people have genetic testing. Some people use genetic testing for family planning. So by knowing the mutation in the family, we can do what's called in vitro fertilization or pre-implantation genetic diagnosis. So they call those IVF and PGD for short. So let's talk a little bit about that. So once we identify a mutation in the family in someone who has Alport syndrome, then they can have their sperm fertilized with an egg and form an embryo, and then that embryo can be specifically tested for that mutation. And only embryos that don't have the Alport mutation would be implanted into a woman's uterus and then develop into a baby. So this is a wonderful way if a family really didn't want to pass on the Alport syndrome and wanted to do in vitro fertilization with pre-implantation genetic diagnosis. So this is something that certainly can be done once a mutation is known in the family. Additionally, prenatal testing can be done once someone is pregnant spontaneously. Someone could also test a newborn baby if they knew a mutation, just to know if they should be proactive about following that individual for Alport. So finally, another reason for genetic testing is what we call genotype-phenotype correlations. In other words, is that what does my genetic makeup look like, and can this help predict prognosis? And we can get some information from genetic testing. It's not perfect. We can't get everything, but it can be useful, and sometimes it's useful information for some clinical trials. So let's talk a little bit more about specific mutations. So when we think of reading a gene or doing genetic testing, we would say chromosomes are kind of like reading a book or looking at chapters in a book. And genes are individual sentences in that book. And when we look for mutations, we're looking for really spelling mistakes within those sentences. So there's several different types of mutations. There's what's called a missense mutations, where there's a spelling, just a change in one word. So here's an example where it says the car was red, and this says the car was hat, or the car was RDD. So there was one word or a letter change. There's other type of mutations called nonsense mutations, where the sentence just kind of ends too soon or abruptly. Oftentimes there's something called a stop codon, or something that stops reading the gene, and then the protein is never being produced. There's other types of mutation as well, called insertion mutations, or a duplication. If there's maybe an insertion of an additional genetic information, or maybe a substitution. And then sometimes there's a deletion, where there's one word or maybe many words that are missing. So for example, we can find there is some prognostic information we could get from these different types of mutations. For example, we do know that the missense mutations, people who have those tend to have later onset of the end-stage renal disease than people with a nonsense or a deletion mutation. So sometimes we can get some information. Again, it's not perfect, but sometimes it can give us some insight of why someone might be more severe than others depending on the mutation. And that's just an area of growing research, is the more we learn about specific mutations, sometimes that can help with, again, prognosis. And sometimes can be useful for clinical trials as well. So let's just kind of summarize some of the genetic testing. So in general, if we look at a family history and we're pretty sure it's X-linked, or we see a specific inheritance pattern, oftentimes we'll just start with testing one particular gene. In other cases where we really don't have a clue of what type of inheritance pattern, we'll often test all three genes for Alport syndrome and do a targeted sequencing panel. Now, rarely, sometimes someone test negative for all of those 3 Alport genes, and there may be something else going on because there are other conditions that are involved in kidney abnormalities and hearing loss. And so sometimes we need to do some more broader testing called either whole exome sequencing or whole genome sequencing, where they were actually looking at the spelling mistakes in the whole chapter, the whole book, not just a specific panel. So oftentimes families have questions about insurance coverage. Does insurance cover genetic testing? And sometimes it does, sometimes it doesn't. Oftentimes, if it's used for diagnostic confirmation, then that can be really helpful that it would be covered. It's pretty typical that we need to test the family member that's affected. So the insurance usually always gets charged for the person who's actually having the testing. So once we identify a mutation in that family member who's affected, then when we test an unaffected family member, we only need to do what's called targeted testing, or looking for that specific mutation, and that's usually less expensive. Typically, what we recommend is have people check with their own insurance, but oftentimes they'll need a prior authorization, and that can be done either through their doctor's office or through the genetic counselor that they meet with. Genetic testing can be expensive, so typically it's several $1,000s. It kind of depends on the lab that's used. So in summary, Alport syndrome can be inherited in an X-linked manner, dominant, or recessive inheritance patterns. The family history and genetic testing is really important to help clarifying the inheritance patterns and recurrence risk. And genetic counselors are healthcare professionals that are master's trained and licensed that can help interpret family histories, provide important emotional support and counseling, and help facilitate genetic testing. So I'm happy to take some questions now.
Wonderful, thank you. So if you have questions, you can feel free to type them in the participant feedback. At the very end, I will be unmuting all of the lines so you can ask questions that way as well. We did get some questions sent in to us ahead of time, although you did a phenomenal job of answering them, most of them, so thank you. How does someone go about choosing or finding a genetic counselor? Is that something that they should speak with their nephrologist about? What is the best way to find a qualified genetic counselor?
Good question. So there's a wonderful website called NSGC, the National Society of Genetic Counselors. So it's just nsgc.org. And there is a link on there where it can be find a genetic counselor. So that's one way. But another way certainly would be either talking to their nephrologist or their primary doctor. And most centers would know who, and typically they would refer to a genetic counselor. So those
and does insurance typically provide or pay for genetic counseling services?
Typically, most insurance companies would cover for genetic counseling services. Again, that's something you'd have to check with your insurance, but oftentimes it's covered. And often there are many insurances that actually, in order for them to pay for genetic testing, they require a meeting with a genetic counselor. So there are some genetic counselors that are available. There's some companies that are online, and so sometimes there are specific companies that one could get contracted to meet with a genetic counselor via the computer or via a virtual setting. But most genetic counselors, you would go in person to meet with them.
Great. And just to clarify, for those, if you have an X-linked male whose mom tests positive for having Alport syndrome gene, she is a patient most likely and should probably seek her own nephrologist and for treatment. Correct? She's not just a carrier; she's also a patient.
Yes, correct. So I mean, we use the term carrier, but carriers can definitely have symptoms, and we do know female carriers of the X-linked Alport syndrome can develop end-stage renal disease. So yes, she definitely needs follow-up. So I suppose that someone thinks that carriers doesn't mean they have symptoms, but in carriers can have symptoms, correct.
Okay, we have a question online. The genetic testings for my son came back negative for Alport, but the renal biopsy suggests highly suspicious of Alport. Should we do genetic testings again like in 1 or 2 years? Will the gene database for Alport get updated regularly?
Okay, so that's an excellent question. So there's a couple things to look at for the genetic testing. So I would make sure that your son got tested for all 3 genes, the COL4A4, COL4A5, and the COL4A3. So first of all, to make sure they had sequencing and what's called deletion duplication. So those would be the most complete ways of looking for those genes. If those were all negative, then that would be a situation where he may benefit from doing some additional like whole exome sequencing, because there are other conditions that may involve those features. So those would be the steps that I would take. And it looks like all 3 were tested. So if they were tested with sequencing and deletion duplication, then there's 2. One could do whole exome sequencing. Sometimes someone might want to do what's called a microarray, or looking at the chromosomes to make sure there's no rearrangement. I'm not sure if there's other issues going on with your son as well, and it's a little bit hard to give advice without kind of a thorough, evaluation and family history. But he may benefit from additional testing, such as a whole exome sequencing. Did that answer your question?
Great. There are no other questions online right now, although you're certainly welcome to ask. I'm going to unmute all lines, so if you have any loud noise in the back, please mute your own line. But if you have a question that you'd like to ask, you can feel free.
The conference has been unmuted.
Are there any other questions?
Yeah, if I can get back to it. Come on.
Okay. Well, if anyone thinks of any questions, both those who are live here, or we do know that the majority of people who are watching this will be doing so after. If you have any questions, please email us at info@alportsyndrome.org. Again, that's info@alportsyndrome.org, and we will make sure to pass your question on to Karol or whomever is appropriate for that. And if you joined this presentation late, if you were watching it live, this will be available on our website, so you can view it at your convenience at any time and share it with your family or anyone else that you wish. Thank you so much again, Karol. We are very appreciative. This was such a wonderfully informative that really made a very complex issue simple to understand. So we're very grateful to that. I know it's going to benefit a lot of our patients.
You're welcome. I'm happy to speak for your group, and please do forward any questions that come up. I'd be happy to address them.
Wonderful. Thank you very much. Enjoy your evening, everyone.
Thank you.